welcome. So basically, I assume that you all have a very strong, you already have a basic knowledge of the hormones of the pituitary itself. Okay, physiology, anatomy, all you already have that knowledge beforehand. So, so, so you have to recall that the knowledge of the anterior and posterior pituitary hormones as well as anatomy. So for this lecture, we are going to discuss on the disorder of the pituitary gland. We only select a few. Okay, there are a lot of disorders, but we are going to discuss on hyperpituitarism. So for this, we are going to discuss on only 3 common hyperpituitarism, which is prolactinoma, acromegaly, and generally is 2. Another one is Cushing disease. We are going to discuss in a more detail about Cushing's actually in adrenal. Okay, all right, and we are going to go through hypopituitarism. Okay, do you all have a case discussion on hypopit with physiologist?
Yeah, we have a case study.
You all dah buat ya that case study done on hypopituitarism.
Yeah, it was fun hypopituitarism.
Yeah, so basically you all have covered hypopituitarism in general. So it's just a repetition. Okay, and then we are going to look on the sign and symptoms. Of course, we have to relate its pathophysiology. Okay, and we are going to also look at the biochemical tests in the investigations of basically in general endocrine disorders. Okay, so the biochemical test of the endocrine disorders. So in this case, we are going to look at the general investigations, biochemical investigations for pituitary disorders, in which we are going to talk a bit about dynamic test, okay, and just very briefly on the treatment. Okay, treatment will be very briefly. Okay, so anatomy of pituitary gland, I'm not going to go through this. So you have to understand the concept of the anatomy, the anterior pituitary, and where is the hypothalamus, as well as other structures surrounding the pituitary. Okay, so you have to understand that, because later we're going to talk about mass effect, in which you're going to relate the pathology in pituitary, which the clinical manifestation in terms of the mass effect. Okay, so anatomy is important, and of course you have to also understand the anatomy of the vessels or veins that runs across the hypothalamus to the pituitary, as well as the nerve plexus. Okay. Okay, so pituitary hormone, this one you have learned already. What are the hormones in the anterior pituitary, and what are the hormones you can find in the posterior pituitary? Okay, when you talk about pituitary disorders, most commonly we are going to talk about the abnormality in the anterior pituitary hormones. Okay, so pituitary disorders mainly would affect hormones of the anterior pituitary. So namely your TSH, your ACTH, your growth hormone, your gonadotrophs, and your prolactin. All right, so knowing all these pituitary hormones, you should be able to relate to what are the hormones in their respective target organs. Yeah. Okay. I have this diagram. This is actually physiology, so I'm not going to go through this in a great detail. It's just for you to always bear this in mind whenever we talk about pituitary disorder, or even disorder of any abnormality of the hormones in the target organs. Okay, you always have to have this in mind. Okay, on the hypothalamic pituitary axis. Okay, so you should have the knowledge of what are the hormones in the hypothalamic, what are the relevant hormones in the pituitary, and what are the hormones in the target organs, and how is it regulated. Okay, so this is physiology, right? All right. So in general, when you talk about pituitary lesions, it can be divided as in acquired defects, okay, or congenital defects, as well as genetic defects, okay. So very common one when talk about acquired defects are the tumors, okay, pituitary tumors, okay. For example, adenomas and carcinoma. Most commons are pituitary adenoma. Okay, other lesions can be caused by trauma, irradiation, inflammation, infection, vascular disorders. Okay, you will come across the terms pituitary apoplexy. What is pituitary apoplexy? Anyone? Anyone? What is pituitary apoplexy? You have not heard of it? No? Is a yes? What plexus? All right. Okay, so you're talking about vascular disorders. Okay, so basically, pituitary apoplexy refers to like sudden bleeding in the pituitary gland. Okay, it can be due to tumor if you have tumor. Okay, and there's bleeding in the tumor, so you can have actually a spontaneous, sudden clinical manifestation of pituitary deficiency. Okay, so it is more or less an emergency situation. Okay, so it's a bleeding. It can be due to bleeding in a tumor, or it can be due to some bleeding disorders. Okay, patient with bleeding disorders, you can have sudden bleed in the pituitary. Okay, and another example is Sheehan syndrome. Anyone heard of Sheehan syndrome? Sheehan syndrome is basically an acute, when there's an acute blood loss, you can have infarction to the pituitary. Usually it occurs in a mother who delivered baby. Okay, in delivery, sometimes you can have a very excess in blood loss, and somehow in a pregnant lady, your pituitary tends to grow a bit bigger. So you tend to have, there's tendency for you to have infarction, okay, when there has sudden increase in blood loss. Okay, empty cellular syndrome. What is empty cellular syndrome?
I think shrinkage of the pituitary, is it?
Okay, when there's a shrinkage of pituitary, okay, it is described as empty cellular because the pituitary sit on the sella thrucica, kan? Set on sella thrucica. So usually when they investigate on the pituitary lesions, they do the CT scan, and if there is shrinkage of the pituitary, it is described as there is the sella is empty. Okay, so it is actually not really empty, as in there's nothing on the sella. Usually there will be CSF. Okay, your cerebral spinal fluid filling in the sella turcica when your pituitary shrink. Okay. All right. So other defects. So you can also have metastatic tumor on the pituitary gland itself. All right. So other defects are congenital defects such as Kalman syndrome. We are not going to talk about it. Okay, pituitary aplasia. So baby born with small pituitary glands. Okay, and there's also genetic defects which also might affect hypothalamus as well. Okay, so there are various lesions in the pituitary which can either cause hyperpituitarism or hypopituitarism. Okay, but I think with when we want for this particular lecture, because we want to describe hyper and hypopit, we are going to concentrate more on the tumors. Okay, because that is most common anyway. Okay, but never forget other causes of pituitary lesions such as vascular disorders as well as inflammatory disorders. Yeah. Okay. So general clinical manifestations of pituitary lesions. Okay, because the functions of pituitary is to produce hormones. Okay, so of course when you have pituitary lesions, you can have hyper or hypopituitarism depending on increase or decrease in the hormone produced by the pituitary. Correct? Okay, so you can have increase in, so that one understood. Okay, so you can have endocrine defects because of abnormal increase or decrease in the hormone by the pituitary. Okay, usually is anterior pituitary. All right, okay. So on top of that, with pituitary lesion or pituitary disorders, you have to also consider the mass effect. Okay, especially when we talk about pituitary adenoma. Okay, or even bleeding. Okay, so when there's bleeding, there's increase in size of pituitary. So you have to relate to the mass effect of the pituitary, because pituitary is a small organ, but there's also other structures surrounding it. Okay, even a small increase in size might give a mass effect. Okay, so it depends on the size. Okay, and the structure related to it. Okay, so the sign and symptoms of the mass effect of pituitary lesion includes headaches, visual defects, hydrocephalus, okay, rhinorrhea. What is rhinorrhea?
CSF leakage through your nasal cavity.
Okay, rhinorrhea just means the fluid coming out from your nose. Yeah, so in this case we have CSF rhinorrhea. Okay, CSF rhinorrhea. So there is the CSF coming out from the nose. Okay, so and you also have to consider hypothalamic syndromes. Okay, so usually hypothalamic syndromes you will have diabetes insipidus. Why do you have diabetes insipidus in hypothalamic syndrome? What is diabetes insipidus?
Lack of ADH.
Lack of ADH. So how does that related to hypothalamus?
It's a neurohormone from the hypothalamus.
Neurohormone. Okay, so it is produced in the hypothalamus, in the nucleus in the hypothalamus. Yeah. Okay, and it is stored in the posterior pituitary, your ADH. Okay, so on top of that, other syndromes that is related to hypothalamic disorders, which is your appetite, okay, your sleep. So that these are all the things that is regulated in the hypothalamus. So these are the things that you also want to look at to indicate the involvement of hypothalamus. Okay, so but it is actually quite rare to, I mean, if you look at anatomically, if there is pituitary lesion, for example, okay, so the lesion has to be big enough to actually affect the hypothalamus, right? Okay, so what are the cause of headaches? What cause headaches in pituitary lesions? Anyone?
I guess increase in the size of the pituitary causes for it to compress on the adjacent structures and causing intracranial pressure.
Okay, it is increase in intracranial pressure itself. Okay, as well as the stretching of the structures surrounding it. Yeah. So this will be presented as headache. Okay, what is increase in intracranial pressure? What does it mean?
Tumor present in the pituitary.
Tumor present in the pituitary. Increase in intracranial pressure is caused by any mass in the brain. Okay, you will learn that in a nervous system. Okay, so any mass in the brain will cause increase in intracranial pressure. When we say increase in the pressure, what pressure are we referring to?
Cranial, intercranial pressure.
Intracranial pressure. Okay, so when we measure it, we actually measure the pressure of the CSF, in the CSF. The pressure in your ventricles, for example. Okay, because your CSF is there. Okay, so there is, because your brain is confined in the structured or hard skull, so whenever there is mass, the brain cannot expand. So because of that, the pressure inside, okay, so mainly we measure the CSF pressure is high. Okay, so that is what it means by increase in intracranial pressure. So that increase in pressure causes compression to the structure surrounding it. Okay, so that means, you know, I'm not sure whether you have not learned the anatomy of the brain. You have not learned that. You only learned the pituitary sahaja, right? Only the pituitary, right? So you have your ventricles, in which the ventricles are the space within the brain, okay, which has cerebral spinal fluid inside it. Okay, so when there's a mass effect, actually these ventricles will expand, okay, will expand, but the brain will be compressed, you know, so the pressure inside is high. So if you can imagine the meninges all will be stretched, so it causes headaches. Yeah. What about visual field defects? How does that related to your pituitary lesion?
Compression of optic
compression.
Compression of optic chiasm. Where is your optic chiasm in relation to your superior? Okay, it sits superior to your pituitary gland. Okay, so what kind of visual field defects would you get in when there's a compression in the optic chiasm?
Bitemporal hemianopia.
Bitemporal hemianopia. What does that mean?
It's tunnel vision.
Huh?
Tunnel vision.
Tunnel vision?
Is it
tunnel vision?
not
Partial blindness.
Partial
blindness.
partial blindness. Okay, so all right, so basically your visual field is divided into four. Okay, so it's if you can imagine your eyes, your two eyes, right? So this eye and this eyes, okay, you divide it into 4. Okay, so this temporal is this side. Okay, so this is medial side. Okay, so usually when you test your visual, you will test whether you can see on this side, this side, this side, and this side. So bilateral temporal hemianopia is actually loss of vision on the half of the temporal side. Okay, because of the optic chiasm, you will because of compression of optic chiasm, you will learn in detail about this in nervous system, how how it works, how it crosses the optic chiasm crosses, which cause when there is compression at the chiasm. Chiasm is at the junction, right, where it crosses. So how does that cause just like one side? Okay. So for this purpose, it's just enough for you to understand that when there's compression to the optic chiasm, there is a loss of half of the temporal visual field. Okay. So what else can happen in terms of vision? What else can happen in terms when you talk about vision besides the visual field?
What about blurry vision?
Blurring vision. Okay. Okay. What about blurring vision? How can you have blurring vision? You can have blurring vision can be there are a few things. One is the optic chiasm. One is maybe the optic nerve itself. Okay, when there is compression, then you can probably have, especially when there's increase in intracranial pressure. We're talking about increase in intracranial pressure here. Okay, it's not necessarily the pituitary compressed on the optic chiasm. Okay, we're also talking about possibly there's increase in intracranial pressure in which your optic nerve can also be compressed. So this you can have visual, blurring of vision. Okay, but actually with pituitary tumor, because pituitary is such a small organ, okay, so it is not very common for you to actually have increase in intracranial pressure like when you have bleeding or you have cerebral tumor. Okay, so yes, you can have blurring of vision. Another one, you can have like double vision because of compression to your nerve that supply the muscle that move your eye, your orbits. Okay, so you're talking about your cranial nerve 3, cranial nerve 6. Okay, so these are the nerve that supply the muscle that responsible for your eye movement. Okay, so this nerve set at the site of your pituitary. Okay, so it can be compressed as well, so you can have double vision. Okay, hydrocephalus. Okay, where hydrocephalus is also if there is extension upwards. Okay, because your hydrocephalus is your expansion of your ventricles in the brain. Yeah, so I mentioned earlier, ventricle is the space where your CSF where filled with CSF in the brain. So so there is like a hole that drains this CSF. Okay, so when there is upward extension of your pituitary, so this drainage can be blocked, and it can cause the accumulation of CSF into these ventricles, and it can lead to the increase in size of these ventricles. Okay, expansion of these ventricles. This is called hydrocephalus. Okay, obstructive hydrocephalus, because the CSF cannot drain, compressed by your pituitary. Yeah. Yeah, there are a few drains that there are a few ventricles. Okay, you will learn this in detail in a nervous system, but there are a few ventricles. There are first, second, third ventricles which are connected to each other. Okay, so there are drainage. Okay, so if the drainage is blocked, okay, so you can have expansion of the ventricles. So in this case, actually, perhaps it's the third ventricles that is associated with your pituitary. Okay, so it can cause obstructive hydrocephalus. All right. CSF rhinorrhea, how does that occur? Anatomically, how does that related?
Maybe the pituitary tumor got too big and it punctured the cellular diaphragma.
The
cellular diaphragma, which is superior to the pituitary gland.
Cellular.
The sphenoid sinuses.
Yeah, it's more of an inferior. Okay, because the sphenoid sinus is inferior to your pituitary. So inferior erosion of the inferior part of the pituitary, okay, can cause effect on your sphenoid sinus. So this sinus is drained into your nose. Okay, so your nasal area. Okay, so you have to go back and relate all this to your anatomy. Okay, how this what symptoms can you have when there's lateral extension? What symptoms can you have when you have superior extension? What symptoms can you have when there's inferior extension? Okay, it's all in your anatomy. All right. Okay, so we talked about hypothalamus. Yeah, the mass effect that can occur when there's involvement of hypothalamus. Okay, so another thing is when you talk about your pituitary stalk. Okay, pituitary stalk is like a bridge that is connecting your hypothalamus to your pituitary. Yeah, so you've learned about you know where the pituitary. So any compression at the pituitary stalk, actually you can have the same effect as in your whatever from your hypothalamus is deficient. Okay, because it cannot drain into your pituitary. So you can have diabetes insipidus as well. Okay, when there is compression at the pituitary stalk. So you can have endocrine effect. Okay, so it's a compression, and so it can fall under endocrine effect, but that's because of the mass effect on the pituitary stalk. So it's the same as endocrine effect. So endocrine effect can be because of the lesion causing increase in production of the particular hormone. Okay, so for example, if you have tumor which produce prolactin, okay, so you can have hyperprolactinemia. Okay, but this particular tumor as well, okay, can compress the surrounding cell in the pituitary. So you can have hypopituitary symptoms as well. Do you get what I mean? Okay, for example, you have tumor of cells that produce prolactin. What are the cells that produce prolactin?
Lactotroph.
Okay, so you have tumor of the lactotroph cells. Okay, for example, so this tumor are a functional tumor, what we call a functional tumor, which secretes prolactin. Yeah, so you can have symptoms of hyperprolactinemia. Okay, so we will talk about it. But at the same time, because this tumor is also a mass, it can also compress the surrounding pituitary. Correct? Okay, so in other words, it can compress other cells in the pituitary. So at the same time, you can have deficiency of other cells. Okay, so you can have, perhaps you can have deficiency of cells deficiency of growth hormone, because the mass also compress what cells that produce growth hormone? Somatotroph. Yeah?
Yeah.
Yes.
Okay, so it can, so the principle is that, so you can, when you have a functional tumor, you can have increase in specific hormone, and on top of that, you might have decrease in other hormones. Okay? All right, so that's why when you have pituitary disorders, you want to check all the hormones. Okay? So that is a general picture of pituitary disorders. Okay? All right. So clinical manifestation, so we've talked about this. Okay? On the mass effect, we've talked about this. Okay, you can look at this relation. Okay? All right. And endocrine effects, we've talked about this as well. So next we go to biochemical investigations. Of course, investigation involve biochemical investigations as well as imaging investigations, which is also important. Okay, but for this lecture, I want to go in a more detail on biochemical investigations because it relates to your understanding of hormone. Okay, we are not going to talk much about imaging investigations. Okay, so biochemical investigations, what hormones do you want to measure? What do you want to measure? When you suspect a pituitary disorder, okay, for example, you suspect this patient probably have pituitary tumor. Okay, what do you want to measure?
The pituitary hormones.
You want to measure the pituitary hormone. Okay, is there anything else that you want to measure? Is it enough to just measure the pituitary hormone?
No.
Also
No.
the hormones produced by the organs themselves.
Okay, so you want to also measure the hormone produced by the organ related to that pituitary hormones. Okay? All right. So this will give a better picture of whether there's hyperpituitary or hypopituitary. Okay? Because if you should understand the regulation, the negative feedback and all that. Okay? So because whenever you have a deficiency in some pituitary hormone, for example, okay, so because of the negative feedback, so that hormone might be normal because the regulation already normalized it. So that's why we want to see the pattern. We want to see the relations, the pattern of the pituitary hormone as well as the target hormone for us to get some idea of where is the defect. Is the defect from the pituitary or is the defect from the target organ? Yeah. So it's not enough to just have a hormone measured of the pituitary only. Okay, so you want to measure both. Okay, what else do you do? What is dynamic test?
We test for which hormone is having a disorder by either stimulating or suppressing it.
Okay, so it is a dynamic test. Some books also call a provocative test. So dynamic test is also a test that usually done mainly to confirmation, to confirm a disorder. Okay, it is basically to challenge. So is mainly to test for the pituitary reserve. It's not only for pituitary reserve, also the hormone reserve of the target organ as well. So that means if you have a baseline, for example, a deficiency in certain hormone, okay, but you want to test whether there is really a deficiency, okay, so you want to try to stimulate. Okay, so if you suspect deficiency, okay, so you want to try to stimulate the pituitary to see whether the pituitary gland have enough reserve to actually synthesize the hormone. You understand what I mean or not? So it's actually a challenge. You want to challenge the pituitary gland. Okay, so for example, if you see some deficiency in the production of pituitary hormone, okay, a certain pituitary hormone, okay, so maybe there is deficiency, but maybe this pituitary gland might still have some reserve of some cells that you can still probably produce hormone with a little bit more of a stimulatory trigger, okay? Or whether there is really deficient in the reserve for producing that hormone, in which even if you put stimulation, still the hormone is deficient. So that is the principle. Okay, so the same goes with when there is excess in hormone. When there is an excess in hormone, okay, you want to try to suppress it, okay, to see whether with further suppression, will this hormone suppress, or will this hormone will be continually produced with more suppression. Okay, so that means you want to exert extra suppression or extra stimulation on top of the usual regulatory, stimulatory, and stimulatory and suppression of the hormones. Okay, so it's a dynamic test. Okay, all right, so you have to sort of understand this, because when you want to investigate for endocrine disorders, it is almost always applicable for you to challenge, to do dynamic tests. Okay, so you have to understand the principles. Okay, so I suppose you understand just now, just the baseline. You need to do a baseline level of the pituitary hormones as well as the target organ hormones. Okay, and you want to do a dynamic test. Okay, for a few reasons. One, because of the pulsatility of the pituitary hormones. So that means if you take the level of that hormones, you might hit the level in which it at its lower when it at its nadir. Okay, so when the secretion is low. So because of this pulsatility, you want to do dynamic test. Okay, so you cannot rely on just a one single measurement. Okay, you want to take a few measurements, and on top of that, you want to challenge it. Okay, so when you suspect insufficiency of hormone, so you want to do a stimulation test. Or when you suspect a hyper function of a hormone, so you want to do a suppression test. Okay, so there are a list of specific stimulation and suppression tests for a particular hormone. Okay, I think I have the list. Yeah, I have the list here. So these are the list of dynamic tests that can be done. There are a lot more. There are other options, but these are just an example of the common ones that is used for a certain disorders. For acromegaly, you use oral glucose tolerance test. We are going to talk about this when later when we talk about acromegaly. For growth hormone deficiency, you have insulin tolerance test, glucagon. We're not going to talk a lot about this. We are not going to cover so much on GH deficiency anyway. Adrenal insufficiency, you have ACTH stimulation test. We're going to talk about this in adrenal disorders. Okay, anterior pituitary insufficiency, we have triple test. Okay, diabetes insipidus, we have water deprivation test. We are going to talk more. Diabetes insipidus are going to cover more when you do urinary system as well. Okay, Cushing's disease, dexamethasone suppression test. So at least you need to understand the principle of this test. You don't have to understand in a great detail of how to do this test. Okay, you just need to understand the principle of this test. Okay, so I will bring you to the specific test when we talk about the disorder. Okay, so at your level, you don't have to know all the tests. Okay, only when you talk about the disorder, then you need to understand the basic principle of the test. Okay. All right. So just now we talked about the causes. So I've already mentioned the common one are pituitary adenoma. Okay. So when you talk about pituitary adenoma, you talk about micro or macro adenoma. So microadenoma referred to adenoma of less than 10 millimeter in diameter. Okay, macro of more than 10 millimeter in diameter. So when there is microadenoma, usually there will be less mass effect. You would expect less mass effect, and usually if it's a functional adenoma, you would expect the increase in level is not so high as compared to a functional macroadenoma. Okay, do you get me? Okay, so you sort of can see the difference when there is increase in a level of certain hormone and it's very high. It is most likely to be a macroadenoma. Okay, okay. So majority of this adenoma are monoclonal. What does it mean when I say when it's monoclonal? Yes?
Go ahead, Lee.
Yes. So majority when it is functional, it is only involve one cell. So it's either growth hormone or it's either prolactin or it's either ACTH. Okay, usually majority is monoclonal, but you will find later when you talk about prolactin, there are a small percentage that you can have prolactinoma with acromegaly as well. Only small percentage. Okay, but enough for you to know. Usually, most of the time, when it is a functional adenoma, it is a monoclonal. It involves only one type of cell. Okay, so it involves only one specific hormone, hyperfunction. Okay, may and may not be functional. So I keep on mentioning if it's functional or it's a non-functional adenoma. So when we talk about pituitary adenoma, it's not always a functional adenoma. Understand? So it's not always an adenoma that increase in the production of the particular hormone. It can be a non-functional adenoma in which it's just increased number of cells with a mass. That's all. It doesn't produce excessive amount of hormone. Okay, so you have to bear in mind whenever we talk about pituitary adenoma, it's not always a functional adenoma. Okay, all right, so it can be functioning, can be non-functioning, and yes, mass effect depending on the size of your adenoma. So when you have a non-functioning adenoma, that doesn't mean that you don't have any endocrine abnormality, okay, because you can still have a mass effect. The mass effect can mean the mass effect on the surrounding structures around the pituitary itself. Okay, we talk about the apa tadi? We talk about headache, rhinorrhea, hemianopia. Okay, so that is concerning compression of the structure surrounding the pituitary. Okay, you ought not to forget also the compression or the dysfunction of the cells of the pituitary itself. Okay, so this is when you can have a hypopituitarism in a non-functioning adenoma. Okay, understand? So you can have compression of the mass, and you can have compression or dysfunction of the cells itself. Your lactotroph dysfunction, your somatotroph dysfunction, okay, your corticotroph dysfunction because of the tumor of the adenoma. All right. Okay, so these are the general picture of pituitary adenoma. So when you talk about prolactinoma, it's the same concept. When you talk about acromegaly, it's the same concept. Okay, except for, so the only difference are the hormone itself, the hormone functions itself. Okay, other abnormalities are the same. The mass effects are the same. Okay. All right, so the prevalence of the pituitary tumor, most of the pituitary tumor, if it's a functional tumor, okay, non-functioning tumor falls about 10 to 30% of the tumor. The rest are functioning tumor. So out of the functioning tumors, most commonly they are prolactin secreting tumor. Okay, next are ACTH producing tumor or growth hormone producing tumors. Okay, other tumors are actually quite rare. Okay, so most common are basically prolactinoma. Okay, growth hormone secreting tumor, acromegaly, ACTH secreting tumors causing what disorder?
Cushing syndrome.
Cushing.
Yeah, that's Cushing's. It's Cushing's disease actually. Okay. FSH tumor is quite rare. TSH is very rare. Okay, I hardly see any tumor that produces TSH. Okay, so as I mentioned earlier, for this lecture, we are going to talk about prolactin secreting tumor, growth hormone secreting tumor, and ACTH secreting tumor a little bit. Okay. All right. Okay, so prolactinoma, acromegaly, and Cushing's disease. Okay, so we go to the case. Okay, these are the case that I put up in your SCTL, right? Okay, so you can quickly go through the case because we've actually already covered quite a lot in a general concept of pituitary disorder. Yeah. Okay, a 30-year-old woman referred to ONG clinic for secondary amenorrhea and galactorrhea. She has missed a menstrual period for 2 months. Okay, however, pregnancy test is normal. Okay, further questioning, she also mentioned that she has noted some milk discharge from her nipples for the past 2-3 months. So these are perhaps the typical presentation of patient with prolactinoma. Okay, usually in women they come with infertility or amenorrhea. Okay, they can come with just amenorrhea. What is amenorrhea?
Irregular menstrual cycles.
Okay. Irregular menstrual cycle. So amenorrhea. So that means perhaps they have missed their period for quite some times. What the secondary amenorrhea means?
Is when they have normal menstrual cycles like regular, and all of a sudden they start being irregular.
Okay.
They start missing their periods.
Right. So for someone who has been having normal menstrual cycle and suddenly they have missed their period for a certain duration of time. Okay. So usually they can come with this. Okay. And so, of course, the first thing that you have to do is to check whether this patient is pregnant or not. Okay, don't just jump straight into prolactinoma or pituitary disorder. Of course, every patient, although if the patient has galactorrhea, okay, even if they come with amenorrhea and galactorrhea and you would think, oh, maybe it's prolactinoma, okay, the first things first, check if the patient is pregnant or not. Because you can have galactorrhea if you're pregnant as well. Okay? All right, so in this case, they check the patient is confirmed not pregnant. Okay, so patient mentioned about the nipple discharge. Okay, so of course at this point of time, you want to check whether you suspect prolactinoma. Okay, so the doctor proceed with blood investigations. Okay, so it was found that the prolactin level is high. Okay, and then the patient is started on dopamine agonist. Okay, so what do you all know about prolactin?
It's inhibited by dopamine.
Okay, it is inhibited by dopamine. All right. So is there, what causes increase in prolactin?
Your TRH and your GnRH.
TRH
and your GnRH.
GnRH can cause increase in prolactin?
Decrease in dopamine.
Decrease in dopamine, okay. So anything that cause decrease in dopamine can cause increase in prolactin, okay. TRH can cause increase in prolactin. So in which condition would you have increase in TRH then? Because you say TRH, yeah? In which condition that you can have increase in TRH?
Secondary hypothyroidism.
Secondary hyperthyroidism. Secondary hyperthyroidism. Okay. What is secondary hyperthyroidism?
It's basically decrease in the production of your thyroid hormone, which has something to do with the pituitary gland, not the gland itself, not the thyroid gland.
Increase? Sorry, can you repeat? Increase in thyroid hormone production, secondary to?
It's to do with the decrease in thyroid hormone production because of damage to the pituitary gland. So it's because of decreased TRH levels. Or
decrease in TRH. So that is secondary hypothyroidism.
Yeah, so it's like when you damage your pituitary, not actually secondary. Yeah, secondary is to do with your pituitary, not your gland itself.
Okay. So because we're talking, somebody mentioned TRH, okay, can stimulate prolactin. Okay, so my question is, in which disorder that you can have increase in TRH? TRH is produced by which? It's produced by?
It's produced by your anterior pituitary.
TRH is produced
from hypothalamus.
It's from hypothalamus. TSH is produced by pituitary. Okay? So the TRH is produced by hypothalamus. So you can have increase in TRH if you have some disease, which tumor in the hypothalamus which causing increase in TRH, okay, which is actually tertiary hyperthyroidism, which is very, very rare. It hardly occur, okay. You can hardly find any TRH secreting tumor. So it has to be tumor in hypothalamus, which produce TRH, right? Another condition that you can have increase in TRH is when you have primary hypothyroidism. Correct? Can you relate?
Doctor, is it not secondary?
Secondary hyper or hypothyroidism?
Hypo.
Secondary.
Hypo.
Secondary hypothyroidism meaning you have low in TSH.
So they give negative feedback to the
Yeah.
hypothalamus.
Yeah. So you'll basically have low TSH levels, so there'll be decreased thyroid hormone. So there'll be no negative feedback on the hypothalamus. So it keeps
Okay.
producing TRH.
Okay. All right. So you can have secondary hypothyroidism in which there is decrease in TSH level. Okay. How common would you have? So again, back to what is common. How common would you get low in TSH due to pituitary disorder?
Quite rare.
Very rare. Okay,
3%.
even if you have hypopituitarism, because of any tumor, okay, because you all have done hypopituitary kan, okay, actually thyroid hormone will be the last hormone which is affected. Okay, thyroid hormone will be the last hormone to be affected when there is hypopituitarism. Okay, but the more common one is actually when you have primary hyperthyroidism. Primary hypothyroidism, and the negative feedback will be increase in TRH. You get what I mean?
Yeah.
Yeah. So this is, I mean that when you say secondary hypothyroid, that can also occur. So that means, but because when there is, because we are talking now also increase in prolactin, increase in prolactin. So which means you have increase in prolactin hormone you have some, when you want to relate it like that, so that means you would have a tumor, okay, that the tumor that causing decrease in TRH. Okay, so that this tumor might also might also compress in prolactin. Even though you say that it cause negative feedback and cause increase in TRH and later can stimulate the prolactin. Okay, but bear in mind at the same time, because you are relating it to compression in the pituitary, in your anterior pituitary in the first place. Okay, so it's a bit ambiguous to say that this is the mechanism which causing increase in TRH, which cause increase in prolactin. The most likely cause usually is primary hypothyroidism. So that means you have some damage to your thyroid gland. Okay, we'll learn about it when we talk about thyroid hormone. Okay, which in turn causing loss of negative feedback and cause increase in TRH. Okay, and cause increase in prolactin. Okay, that is more more correlate with the whole situation when we say TRH causing increase in prolactin. Okay, so it's a primary hypothyroidism. So one of the cause, so you will learn later that in hypothyroidism, you might have disturbance in your menses as well. Okay, because one of the reason is also because of this. It disturbs, it causes increase in prolactin. And what does prolactin do? What are the effects of prolactin? Physiology.
Milk ejection.
Contraction of uterus.
Contraction of uterus?
Gas is oxytocin.
That's oxytocin.
Yeah.
Inhibition of your GnRH. So there's decreased production of your LH and FSH.
Okay. All right. So remember, prolactin, besides the milk production, it also inhibits your GnRH, your LH and FSH. Yeah. Okay. So that's why this patient comes with symptoms of hypogonadism. Yeah, because of effect of prolactin on your gonadotroph. Okay. So the same thing when you talk about hypothyroidism, you can also have that effect. It can be because of this. It can also be because of a direct effect of the thyroid hormone. But just bear in mind of this relation. Yeah. Okay. Yeah. So other cause we talk about anything that inhibits your dopamine can cause increase in prolactin, correct? Because in the regulation of prolactin is actually prolactin is continuously produced, but it is regulated by inhibition by dopamine. Where does dopamine comes from?
Hypothalamus.
Okay, so dopamine comes from hypothalamus. Okay, so any disturbance of dopamine to inhibit prolactin, okay, can cause increase in prolactin. So what can inhibit dopamine? What can cause decrease in dopamine? Anyone?
If there's damage to maybe the pituitary stalk in the brain.
Yes, damage in pituitary stalk. Okay, so we mentioned there's no pituitary stalk. You can have pituitary stalk damage. Okay, when there's pituitary stalk damage, you can block anything from hypothalamus, okay, into the pituitary. So you can have all the symptoms of hypopituitarism. But on top of that, you might have increase in prolactin because there is a lack of inhibition of prolactin by the dopamine. Okay. So yes, pituitary stalk damage. Okay, so compression of the pituitary stalk or pituitary stalk damage, it can occur in trauma. Okay, it can occur in infection. Okay, others are drugs. There's a lot of drugs which are dopamine antagonists. Okay, so any drugs which block your dopamine, that actually can cause increase in prolactin. So in other words, there are a lot of causes of increase in prolactin. Okay, it's not only pituitary. It's not only pituitary cause. So you have to also, when you are investigating this patient, you also need to rule out other causes, especially whether there is drugs. Okay, pregnancy, estrogen can cause increase in prolactin. Suckling reflex, okay, can stimulate milk production, increase in prolactin. Okay. Okay, so prolactinoma, we talk about this most common pituitary tumor. Okay. I've mentioned earlier, there might a small percentage there are also mixed tumor in which there is also growth hormone produced together with prolactin. Okay, so it may or may associate with acromegaly, more in women. Okay, so so in microadenoma, okay, you can have prolactin, high prolactin, but it is not so high, okay, which is in the range of 1,000 to 5,000 milliunit. Okay, whereas in macroadenoma, okay, you would expect the prolactin level is very, very high. Okay, so in microadenoma, usually is in women. So in macroadenoma, okay, you see, so if prolactinoma occur in men, usually is macroadenoma. Okay, so in macroadenoma, usually you have to look for the sign and symptoms of mass effect. Okay, okay, what about this one? Note the difference with macroprolactinemia. What does that mean?
There's a lot of prolactin in the blood.
Lot of prolactin in the blood. Okay, what about, but why is it macroprolactinemia?
Is it type of macroadenemia?
Macroadenemia. Okay, macroprolactinemia, okay, refers to prolactin which appear big. Okay, macroprolactin is there's the word of macroprolactin. Okay, because sometimes it is mistaken which when we say macroprolactinoma, it refers to, because it's noma. Okay, it refers to macroadenoma of pituitary of prolactinoma. You see, prolactinoma means pituitary adenoma which produce prolactin. Correct? So macroprolactinoma is if the prolactinoma is of macroadenoma. If it is a macroadenoma, it is called macroprolactinoma. Okay, macroprolactinemia is a totally different thing. It's just means that there's a lot of prolactin which is big in size that you can find in the blood. Okay, so this big prolactin is because of prolactin binds to IgG. Okay, so somehow this prolactin can bind to immunoglobulin in the blood, so the prolactin appears big. So this big prolactin, when you measure in the lab, okay, it can appear that the prolactin level is high. So somehow it is detected in the lab that the prolactin level is high. But actually your prolactin, the functional prolactin level is actually normal. It's just that this prolactin, but somehow some patients have a lot of immunoglobulin that can attach to this prolactin. Okay, so and you can form a lot of macroprolactin in the blood. So when you measure in the blood, there is very high prolactin, but the patient doesn't have any sign of symptoms or anything that suggestive of prolactinemia. Okay, so this is the thing that is quite common that can occur in the lab. You know, patient is investigated for pituitary disease, and you measure your prolactin, and then you found that the prolactin level is very, very high, but the patient doesn't have any sign of symptoms of hyperprolactin. Okay, so you have to suspect macroprolactinemia. So these are just some what we call lab error. It is more a falsely high prolactin. Okay, macroprolactinemia. I put out here because it is quite common that you see in the lab. Yeah. Okay. So I'm not going to talk about prolactin because you have learned this in your physiology about the hormone itself. Okay. So yeah, we talked about this, the regulation. Okay, it is increased with sleep, stress, nipple stimulation. So there are a lot of other things that also can cause increase in prolactin, but it should not be very, very high. So whenever you measure the prolactin, okay, if the prolactin is slightly high, okay, you cannot just straight away jump into prolactinoma, okay, because other causes of increase in prolactin. So we mentioned that just now, dopamine inhibition by dopamine. Okay, so any physiological cause of increase in prolactin, this usually will increase in prolactin, but it shouldn't be very, very high. Okay. Estrogen also can cause increase in prolactin. Okay, so when there is adenoma, usually it is at different level of high prolactin. Okay. So again, I don't want to go into this. This one is just to supplement your notes lah, so that is easy for you to refer when you read the notes. Okay, so we've talked about action of prolactin. Okay, so remember, besides lactation, prolactin also suppress your GnRH. Okay, that's why patient can come with amenorrhea and infertility. Okay, and on top of that, it also have some immunomodulation effects. Okay. Okay, so we have talked about this just now, yeah. Surgery. Please stop. Okay, drug-induced, other systemic disorders, chronic renal failure, for example. This one is mainly because of retention of in chronic renal failure, because of retention of the hormones cannot be excreted out. Primary hypothyroidism. Okay, we mentioned about primary hypothyroidism just now. Okay, so there you go, your macroprolactinemia, big prolactin. Okay, all right. Again, the list, this is for you just to read. Okay, so clinical manifestation, patient can come with hypogonadism, galactorrhea, and tumor mass effect. Okay, in men, okay, they don't come with galactorrhea, but they come with gynecomastia instead. Okay, what is gynecomastia? Anyone?
Enlargement of men breast.
Enlargement of the size of breast. So you don't expect to squeeze and find whether there's milk or not coming out. Yeah. So they don't usually come with galactorrhea lah, but they can come with infertility problem and with gynecomastia. Okay, and tumor mass effect, because just now we say usually if it occurs in men, it is of a macroadenoma. Okay, more than 10 millimeter in size. Okay, all right. So we've talked about this. Diagnosis is measuring the level, the level of prolactin. Okay, so usually if it's less than 50, usually it's because of physiologic cause. Okay, physiologic cause. Just now we talk about suckling reflex. Okay, drugs. Okay. If it's slightly higher, you can suspect pituitary stalk compression. Okay, so this is of a non-functional pituitary adenoma which compress your pituitary stalk. So you can have increase in prolactin, but usually it is not as high as your functional prolactinoma. Okay? Treatment, you give dopamine agonist, for example, bromocriptine and carbamazepine. Okay, so this usually can successfully suppress your prolactin secretion. Okay, you can do surgical therapy if there is adenoma and if it is if the drug fail. Okay, if it's removable depending on the size, okay, you can proceed with surgical intervention. Most of the time with drug therapy, it can shrink out the size of the tumor, okay, and radiotherapy, okay. Okay, so can we move to acromegaly? How much time do we have? We only have half an hour. Okay. Okay, we have limited time, so we can go very, very quickly. Acromegaly, yeah, because we concentrate on the hormone now, the effect of the hormone. Mass effect you all know already. Okay, so acromegaly, a 40-year-old, this is just a typical presentation of a case with acromegaly. A 40-year-old man referred by a dentist for investigations of acromegaly. So the presentation was, they noticed that the jaw becomes more prominent, teeth are more widely spaced over the past few years, and the patient have mass effect, okay, complaints of headache and visual disturbance. So in the investigation, okay, so the random growth hormone level was high, okay, and plasma IGF-1 is also high, okay. What is the relationship between growth hormone and IGF-1?
IGF-1 will inhibit growth hormone when it's released.
IGF.
Your growth hormone stimulates the production of IGF-1 from the liver.
Yeah. Okay. So growth hormone. Okay. So when you have acromegaly, increase in the production of growth hormone. One of the action of growth hormone is to stimulate the synthesis of IGF-1 from the liver. So actually, the whole effect of increase in growth hormone can be either the direct effect of the growth hormone itself, as well as the effect of your IGF-1. Okay, so in fact, when you investigate your acromegaly, IGF-1 is more stable, is preferable because growth hormone secretion is pulsatile, is fluctuating. Okay, so you might want to take several sample. Okay, so you might miss the peak even. Okay, so IGF, and because growth hormone is also influenced by many other factors, for example, stress. Okay, so that can influence your growth hormone. So where else IGF-1 is quite stable. Okay, so it is it's a more reliable test to see to indicate your growth hormone level. Yeah. So acromegaly refers to a clinical syndrome results from excessive growth hormone. Okay, so it can be either acromegaly or gigantism. Gigantism refers to increase in growth hormone in children. Okay, so what are the difference when you have increase in growth hormone in adults as opposed to increase in growth hormone in children?
The bone, because
Yes.
in adult the bone already messed up, but in children doesn't close up yet.
Okay, all right. So in children, you can have the effect on the long bone. Okay, because the fusion is not there yet. So you will have increase in height. Where else in adult, because you stop growing already, so it doesn't affect the long bone so much. So you can have increase in other bones such as skull and your jaws and of the facial features and all that. Okay, so you don't expect increase in height. Yeah. Okay. So I don't want to go into this as well because this is physiology. Remember the regulation of your growth hormone. It is inhibited by somatostatin. Okay. So this one's just to show what can affect your growth hormone. So actually there are so many other factors that can influence your growth hormone. Okay, your glucose level can also influence your growth hormones. So glucose can actually increase your somatostatin, so that can actually decrease your growth hormone. Yeah, okay. So stress can increase your growth hormone. So that's why we say the growth hormone secretion is not always a reliable test because there's a lot of other influences as well. Okay, so causes of acromegaly, okay, can be divided into GHRH independent or GHRH dependent. Okay, so the most common are the GH growth hormone secreting pituitary tumor. Okay, but bear in mind you can also have other cause of GH acromegaly, which can be ectopic production of growth hormone by other tumors, for example, pancreatic tumor and lung tumor, which can produce a lot of GH. Okay, this ectopic production you can also have production ectopic production of GHRH. Okay, and it can also be part of multiple endocrine neoplasia. Have you learned about MEN 1, MEN 2, MEN 3? Multiple endocrine neoplasia. These are a familial endocrine neoplasia, which is categorized into a few combination of endocrine disorders. I think Dr. Bushra will teach you this, MEN 1 and MEN 2. So GH acromegaly falls into the group which called MEN1. Okay, so it can occur together with other endocrine disorder. So MEN1, if I'm not mistaken, is a parathyroid adenoma or parathyroid hyperplasia. Also can occur together if the cause is because of MEN1. Okay, but the most common are pituitary tumor which secrete growth hormone. Okay, all right. So 95% of GHRH dependent tumor are GHRH independent. Sorry, this is a typo. GHRH independent tumor, 95% is because of GH secreting pituitary adenoma, and 80% of this adenoma are macroadenoma. Okay. So what are the actions of GHRH? Okay.
Increase amino acid uptake.
Okay. Increase amino acid uptake.
Increase protein synthesis.
Increase in protein synthesis. Yep.
Gluconeogenesis.
Okay. Gluconeogenesis. Glucose uptake. Okay.
Lipolysis.
Lipolysis. Okay. So it causes breakdown of your lipid, which can cause increase in your free fatty acid in the blood. Okay. I would like you to study this diagram, okay, because this diagram summarizes the effect of your growth hormone as well as your IGF, okay. So you can see the growth hormone can have insulin-like effect as well as your anti-insulin-like effects, okay. So even in a muscle, okay, so in muscle it can have insulin-like effect in which it increase in protein synthesis and amino acid uptake, but it can also have anti-insulin effect on the carbohydrate. Okay, so it can cause decrease in glucose uptake. So as a result, you can have increase in glucose level. Yeah. So it can cause decrease in glucose uptake in the muscle, decrease in glucose uptake in the adipose tissue. It is also cause increase in lipolysis. Okay. So increase or breakdown of adipose tissue, which cause decrease in adiposity. Yeah. So you can increase in your lean mass. So decrease in fat, but increase in muscle. Yeah. Okay, but and also it can so it can increase in protein synthesis. There's increase in RNA synthesis, so that's why you can have increase in production of your soft tissue, your collagen, and all that. Okay, which is translated mostly as a function of IGF-1. Okay, so IGF-1 mainly plays a role in the increase in bone size, okay, as well as other organ size, okay, by increase in protein synthesis function. Okay, so IGF-1 have some insulin-like effect, so that's why it has some similarity in a function as in the structure of insulin. That's hence the name of insulin growth factor. Okay, so study this diagram because you already have learned the effect of growth hormones, right? So that effect of growth hormone, you translate it into the clinical manifestation of acromegaly. Okay, it can be local mass effect. We have talked about mass effect. Okay, so you can have hyperprolactin with growth in acromegaly. So when you have acromegaly with high prolactin, it can be due to two causes. It can be co-secretion of prolactin because by the tumor, or it can also be because of the tumor compressing pituitary stalk. Okay, it can be either two cause. Okay, so others are the same as we talked about the mass effect just now. Okay, so other signs and symptoms are the effect of excess of growth hormone itself. Okay, which causing increase in tissue size, increase in bone size. Okay, so patient comes with coarse facial features, which described as frontal bossing, okay, of the forehead, large nose, lips, and large hands and feet. Usually they complain of increase in size of their shoes. Okay, they cannot wear their rings anymore, so it is a progressive effect. It doesn't occur in a few months, it occurs within years. Okay, increase in size of your tongue, thickening of your pharynx. The patient can have sleep apnea. They can have carpal tunnel syndrome because of a soft tissue of the wrist increasing in size. Okay, they can have joint pains. Okay, the patient can have organ increase in size of the organs. For example, your thyroid as well as your heart size. The patient can have hyperthyroidism. They can have a heart failure. Okay, hyperhidrosis. Okay, this acromegaly has also been associated with polyps, colorectal polyps. Okay, so these are all because of the effect of growth hormone. Okay, as well as the metabolic effects. Okay, so the patient can have hypertension. Okay, because of volume expansion, insulin resistance. Can have diabetes, remember, because we say the patient can have increase in gluconeogenesis, decrease in glucose uptake, and also it has anti-insulin effect. Hypophosphatemia mainly because of increase in turnover of bone. Okay, so cardiovascular effect because of cardiomyopathy, increase in size of the heart. Okay, as well as because of increase in size, there's increase in demand. Okay, so it will eventually, you can have heart failure. Okay, so on top of that, you also look for the sign and symptoms of hypogonadism because of perhaps hypopituitarism comes together with the pituitary tumor. Okay, because it can be macroadenoma. Yeah. Okay, so yeah, so I think that's all about acromegaly. So this picture shows the change in the facial feature of this lady. Okay, from 1916 within 20 years, so it has changed into more coarse facial features. Okay, this is another example in men. Okay, all right. So investigation. We mentioned just now growth hormone. You measure baseline growth hormone. You can also measure IGF. Okay, which is more stable. Okay, so this is when you want to do dynamic test. Okay, so in acromegaly, because it is increased in hormone production, so in a dynamic test, you want to try to suppress the growth hormone. Okay, so one of the way to suppress growth hormone is by giving glucose. Remember, just now we say I show you in the diagram, one of the factor that can decrease growth hormone secretion is the glucose. So glucose increase somatostatin. So somatostatin inhibits growth hormone. So glucose inhibits decreased growth hormone. So one of the tests that can be done to try to suppress the growth hormone is by doing oral glucose tolerance test. Okay, so you give glucose in trying to increase in growth hormone. In a normal subject, you would see, it tried to suppress the growth hormone. In a normal subject, you would see the growth hormone suppressed to a certain level, certain concentration after giving the glucose. Okay, whereas in a patient with acromegaly, okay, when you give glucose, there is a failure of suppression of growth hormone. Okay, you might see some suppression, but to say it's a positive suppression, you want to see whether this growth hormone can be suppressed to less than 1 microgram per liter or less than 2 milliunit per liter. Okay, you might expect some suppression. Okay, because the normal cell that produces growth hormone is still there. Okay, you might see some suppression, but for you to say it's acromegaly is even if you give that much glucose, so there's certain level of glucose that you want to give. Okay, so with this amount of glucose, you would expect the growth hormone to be suppressed to less than 2. Okay, so in a patient with acromegaly, if you give this much of glucose, you can see some suppression, but it is not suppressed to less than 2. So this can confirm acromegaly. Okay, so you want to also do other hormone to check for any hypopituitarism. All right. Okay. So others, so on top of biochemical investigation, you want to also do imaging investigation. Okay. So management, you want to do surgical, radiotherapy, or dopamine medical therapy. One of the way is you want to give somatostatin. You can give GH receptor antagonist. You can also give dopamine agonist, which is found to also cause inhibitions of your growth hormone. Okay. This is how they do a transsphenoidal surgical resection of your pituitary. Remember, your sphenoid from your sphenoid sinus. Okay. Next is Cushing's disease. I think I want to skip Cushing's because we are going to talk more about Cushing's in adrenal disorder. Okay, but bear in mind, Cushing's disease accounts for 60 to 70% cases of Cushing syndrome. So because of that, you will see they're slightly different and say Cushing syndrome just means disease caused by increase in cortisol, whereas Cushing's disease is caused by increase in ACTH. So that means the increase in cortisol is because due to pituitary tumor which secrete ACTH. So this is specifically called Cushing's disease. Okay, so if you have increase in cortisol because of adrenal disorder, okay, increase in adrenal tumor secreting cortisol, we don't call it Cushing. That is not called a Cushing's disease. Cushing's disease is specific for increase in cortisol due to increase in ACTH production by the anterior pituitary. Okay, so you will have all these signs and symptoms which we will discuss further in adrenal disorder. Okay, this as well as the biochemical investigations. Okay, do we have time for hypopituitarism? Okay, hypopit. You already have your apa ni case study. So I suppose in case study you already cover quite a lot on hypopituitarism. Okay, so I just describe a case here. A 30-year-old man presents with lethargy and depression, also complains of loss of libido for the last 1 year. He also complains of frequent dizziness when getting out of bed in the morning. Okay, an examination, he is pale with thin hair and thin eyebrow, axillary hair and pubic hair, and other systemic examinations are normal. Okay, so what does this indicate? Why lethargy and depression?
Lack of thyroid hormone.
Thyroid hormone, okay.
Lack of cortisol.
Cortisol, yeah, okay. Cortisol, okay. Loss of libido is because of your
LH, FSH.
okay, your gonadotropin. Dizziness. What about feeling dizzy when getting out of bed in the morning?
Mass effect.
Mass effect? What does this mean? Low blood pressure. Okay, why do you think this patient have a low blood pressure? Sorry?
Because there's lack of thyroid, so there's less activation of the cardiovascular system.
Lack of thyroid causing lack of activation of
The cardiovascular system.
Cardiovascular system. Lot of activation. You mean so that means your heart is not activate. Die lah, that means.
I mean, basically, like the cardiac output is decreased.
The cardiac output is decreased. Okay. Cardiac output is decreased. Yes.
Because of decreased glucocorticoid and mineralocorticoid, because mineralocorticoid plays a role in the retention of water, which helps to increase your blood pressure.
Okay. All right. So decrease in blood pressure in this case, it is more of a hypovolemic kind of decrease in blood pressure, because this describes postural hypotension. Okay. So this is I think when you want to relate with thyroid, it is more of a sympathetic activity lah. Okay, decrease in sympathetic, which probably, okay, so decrease in sympathetic activity, but this is more on a decrease in glucocorticoids and mineralocorticoid effect. But because mineralocorticoid, the regulation doesn't comes from the pituitary. Okay, but when you talk about decrease in ACTH, which causing increase in cortisol, cortisol also does have some mineralocorticoid function. Okay, so you will have effect like decrease in mineralocorticoid as well when there is decrease in cortisol. Yeah, so it's more of a decrease in water retention. Okay, and plus cortisol have a permissive effect for ADH function to let the water out. It's a permissive effect. It doesn't stimulate, but in order for your ADH to be able to for decrease in ADH, there is decrease in ADH, so that means you want to remove the water. Never mind, that will confuse you more. Yeah.
It has a permissive effect on the epinephrine and norepinephrine.
As well, yes. Yeah, it has a permissive effect. So that is more of a sympathetic. Okay, so decrease in sympathetic. Okay, but another one is, yes, some mineralocorticoid effect of glucocorticoid. Okay, pale, thin hair, eyebrow.
Lack of growth hormone.
Growth hormone, okay. All right. So blood investigations. So in this case, remember we mentioned earlier, you have to do the series of blood investigation of the hormones of the pituitary as well as the target organ. So what does this show? The cortisol is normal. Right, the cortisol is normal. Growth hormone is low.
Thyroxine is low.
Thyroxine is low. Okay. TSH is normal. Okay. Testosterone is low. LH, FSH both are low. Okay. Prolactin is low. So almost everything is low except for cortisol. Yeah, almost everything is low except for cortisol. So why is cortisol not low? Why is cortisol is normal?
Only the corticotropes are not affected.
The corticotropes are not affected. Okay, maybe the corticotropes are not affected yet. Okay, or maybe there is a decrease in ACTH, but because of there is enough reserve of pituitary gland for ACTH, so with the negative feedback, Okay, so there will be, so the cortisol is normalized.
Doctor,
Okay, so because ACTH is not measured here, so you might see decrease in ACTH. Oh no, so you might see decrease in, you might have decrease in ACTH, but so decrease in ACTH and causing decrease in cortisol, but because of negative feedback, so ACTH can still be produced with enough reserve in the pituitary gland, so you have the cortisol is normalized. Anything?
Yeah.
Yes?
The patient be on steroids.
Maybe. The patient might be on steroid, yeah. Okay, so this is an example of hypopituitarism. Okay, so in fact, almost all of the growth hormones, in fact, almost all of the pituitary hormones are low in this case. Yeah, except for like this one, you know, thyroxine. The thyroxine, the total thyroxine is low, but the TSH is normal. Okay, because there is enough reserve of TSH, enough reserve for pituitary to still produce TSH. And like I mentioned earlier, in hypopituitarism, actually TSH will be among the last hormone to be affected. Okay, so there might be some decrease in TSH to the extent that your total thyroxine is low, but because of enough reserve and there is a negative feedback, yeah, inhibition of the negative feedback, so your TSH is normalized. Okay, so you can have this kind of pattern when you do blood investigation, biochemical blood investigation. So it's not always low, 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 low. You can see low and normal. It all depends on how much reserve the pituitary gland has for that particular cells, yeah, and also the timeline. Okay, so when you have hypopituitarism, it doesn't mean that all the hormone will be affected at in one go. Okay, so it is usually gradual. Okay, so it depends on the cause. So skull X-ray shows enlarged cellular tessica. So what does it mean? Enlarged cellular means there's a mass there. Okay, so it is, remember just now we say if it's shrink, you describe it as empty cellular. Enlarged cellular is described by the, in a report of a skull X-ray, usually it means there's a mass in a pituitary. Okay, so CT brain confirms pituitary tumor. So this patient is diagnosed with hypopituitarism. Okay, so clinical features of deficiency are usually absent until 70% of the gland has been destroyed. So that's why you don't usually have deficient in all pituitary hormone, okay, because pituitary gland have so much reserve to still produce the cell. Okay, so it will gradually be affected, depends on the cause. Okay, so pan-hypopituitarism refers to when all the hormones are deficient. All the hormones of anterior pituitary are deficient. Okay, so causes can be because of destruction of damage by tumor, can be because of infarction. So when it's infarction, when there's bleeding, pituitary apoplexy, you are looking more into a sudden hypopituitarism. So this is when you start, you actually have the symptom is more of a decrease in cortisol. Okay, because bleeding or a sudden infarction or bleeding related more into stress and a sudden damage to the whole tissue. So the first sign and symptom will be the effect of cortisol. Okay, because this is when the cortisol needs most. So the effect will be more cortisol as opposed to when you have tumor. Tumor, it is more of a gradual effect. So you start to see more of effect on the growth hormone, but in adults, perhaps you don't quite see the effect of growth hormone, because even if the growth hormones go down, okay, you don't see the clinical manifestation of low in growth hormone so much in an adult. It is more relevant in children, okay. So you probably will see more of a hypogonadism, a decrease in libido, that sort of things, and followed by your cortisol, your thyroid, things like that, you know. So it depends on the cause. So at a more acute, you will have sign and symptoms more on your cortisol. So deficiency in cortisol, we will discuss that later in adrenal insufficiency. Okay. Head injury as well. It can be gradual if the bleeding is slow. Okay. So it really depends on the cause. Okay, so clinical manifestation. So usually growth hormone, gonadotropin, followed by that sequence, growth hormone, gonadotropin, then only your cortisol, your TSH, okay, and your prolactin. Okay, so again, remember your prolactin can be high if it's affect it affects your pituitary stalk. Okay, if it's rapid pituitary damage, you might see sudden ACTH deficiency. Okay, yes, that's all. So this list shows your deficiency, the features of hypopituitarism related to the different hormones that is affected. And remember, you can also have diabetes insipidus. Oh, okay. So this one you can read lah. Okay. Okay. So I want to go a little bit on the dynamic test. Okay. So in hypopituitarism, you want to try to stimulate the hormones. Okay. So there is a test that we call triple function test, in which you do these three tests to try to stimulate all the three hormones. So what you want to give is you want to do insulin-induced hypoglycemia in trying to stimulate your growth hormone and your ACTH. Okay, so hypoglycemia can stimulate your growth hormone. Okay, because we say glucose can suppress your growth hormone, right? So hypoglycemia can stimulate your growth hormone. Okay, insulin-induced hypoglycemia can stimulate your ACTH due to stress. Okay, hypoglycemia, induced hypoglycemia will lead to stress. So stress can stimulate your ACTH. So that is the principle behind the insulin-induced hypoglycemia, how it can stimulate your growth hormone and ACTH. Okay, so is the hypoglycemia itself as well as the stress induced by hypoglycemia which stimulate ACTH. You can do TRH stimulation test to stimulate first your prolactin as well as your TSH. Okay, and there's GnRH stimulation test. Okay, so you can further, so after the baseline test of the hormone, you can further do this dynamic test to check whether there is adequate pituitary reserve or not. Okay, so if with this test if this test shows there is a failure to stimulate all these hormones, okay, then you can say that this patient are having hypopituitarism. Okay, so the test can be done individually or combined. Okay, right. So also imaging tests can be done. I'm not going to go through imaging tests. Okay, so a little bit about diabetes insipidus. So another thing that you want to look for when there is pituitary tumor, so remember we talked about what might cause diabetes insipidus. One, if it's involved hypothalamus. Okay, another one if it's involved pituitary stalk. Okay, so it is less likely for a pituitary tumor to be so big to also involve the hypothalamus actually, unless the initial lesion itself is in hypothalamus. Okay, so you can have diabetes insipidus on top of hypopituitarism. Okay, otherwise pituitary disorder which affect your pituitary stalk, okay, then you can have diabetes insipidus, okay, because inability of your vasopressin. Okay, so what is diabetes insipidus is decrease in the production of your vasopressin. Okay, so what is the function of your vasopressin? Is for your water, salt and water retention. It's for water retention. Okay, so when you have decrease in vasopressin, so you would expect there is an inability to conserve your water. Okay, so that means you will secrete a lot of water through urine. So you will have polyuria. Okay, so when you excrete a lot of water, so you would expect your urine to be very diluted. Okay, so you will have decrease in urine osmolarity, and on top of that, you would expect your plasma osmolarity to be very high. Okay, you have a very concentrated plasma with a very dilute urine. In a normal person, when you have increase in plasma osmolarity, for whatever reason you have increase in plasma osmolarity, so your urine osmolarity will also be high because you are producing concentrated urine. You want to conserve the water because your aim is actually to normalize the plasma osmolarity. Okay, so in this case there is and vice versa, when there is decrease, when there is a dilute plasma for whatever reason, okay, so your urine will be dilute as well because you want to remove the water. The intention is to normalize your plasma osmolarity. So in a diabetes insipidus, there is a discordant in which you will see that the urine osmolarity is very low, which is dilute, and the plasma osmolarity is very high. Okay, so which means that you are not able to concentrate your urine in order to normalize your plasma osmolarity. Okay, so you keep on flushing out fluid. Okay, so that is diabetes insipidus. So if patient will present with polyuria, and because of polyuria, you have polydipsia. Okay, so how do you confirm? So what are the dynamic tests that you can do is a water deprivation test. So that means you want to try to stimulate your ADH, your vasopressin. So how are you going to stimulate your vasopressin? You want to create a very concentrated plasma by depriving water intake. Okay, it is a very dangerous, so you have to really monitor patient vital signs. But that is what the rationale behind the water deprivation test. You want to try to stimulate the production of your vasopressin, okay, by stimulating a condition where with a very high plasma osmolarity, okay. So in a normal person, if you deprive a person with deprived with water, so you stop the water intake, okay, so patient will produce ADH in order to conserve water. Okay, so in diabetes insipidus, so that your plasma osmolarity will remain still very high. Okay, with your urine osmolarity are not able to be to. So what you do, you stop water. Okay, you measure plasma osmolarity and you measure urine osmolarity. So in a normal person, you would expect the urine osmolarity will be increased to the maximum because you want to produce a concentrated urine. But in a diabetes insipidus, okay, you will see the plasma osmolarity will be higher, okay, because it is not able to be normalized, okay. Plasma osmolarity will be higher and the urine osmolarity is not increased, okay. So that is the rationale. So I think the rest you can read lah, okay. Yeah. Any questions? Any questions or not?
Doctor?
Yes.
For stress, is it stimulate the CRH or ACTH or both?
Sorry?
For stress condition, is it stimulate the CRH in the hypothalamus or ACTH or both?
It is known to cause increase in ACTH. I'm not quite sure on CRH, but CRH as well as ACTH actually can be influenced by so many things as well, you know. So I suppose it probably can also cause increase in CRH to a certain extent. But when you want to test for this test in particular, you want to test the effect on the pituitary hormone, because we can also do CRH stimulation test, as in giving CRH. You see?
So actually stress can stimulate ACTH production. Okay. Directly.
Yeah, it can stimulate ACTH directly.
Okay.
Anything? Any questions? Any question about diabetes insipidus? You will learn more diabetes insipidus in urinary system. Okay, so this one you can read lah. The diabetes insipidus itself is the topic of urinary system because it can cause by two pathology. Okay, it is called cranial diabetes insipidus, which what is concerned right now is cranial diabetes insipidus. Another one is renal diabetes insipidus. Okay, so that's why in urinary again you will learn about diabetes insipidus. But for when we talk about pituitary, it's enough for you to understand what diabetes insipidus is, okay, and a little bit of the biochemical investigations that is related to it. That's all. Okay, but I have like extra notes here, your cranial versus nephrogenic diabetes insipidus. So nephrogenic, you are talking more about defect in the receptor that helps in water to go out. Okay, the receptor for your vasopressin in the kidney. rather than the synthesis of vasopressin itself from the hypothalamus and the pituitary. Okay, any other questions? I think with the notes that I give, you can further read. You can further read the notes to enhance your knowledge, because I assume you already have done your own reading. Yeah. Okay, so these are just extra. Other cause of polyuria is just extra notes for diabetes insipidus, because it is not easy to diagnose diabetes insipidus. You have to rule out other causes first. Diabetes, CKD, you have to rule out all these causes before you actually diagnose a patient to have diabetes insipidus. Okay. Yeah, the water deprivation test is here. Any other questions before we stop? If there's no question, can we